Tradition says that at this point I should make a few remarks about the CV of our keynote speaker and bring him to the podium. I hope you'll forgive me if I do something a bit more personal. Back in the COVID days, I was the chief executive and system lead for Birmingham and Solihull, one of the hardest hit areas in the country with COVID. It was a terrible time. It was the worst of times. It was also, in some sense, the best of times in terms of the response that people made on the ground. We had 2,000 people working in ITU who had never been into an ITU before in order to maintain our service. What you will have heard last week in the COVID inquiry was not, for those of us on the ground, a revelation. It was a confirmation of something we all knew. However, in that turmoil and turbulence, there were some people we could look to for genuine leadership and authority. It is my enormous pleasure and privilege to introduce one of those people this morning, somebody whose intellect, whose knowledge, whose wisdom, whose moral integrity shone throughout the whole of that COVID crisis. So, without further ado, someone who doesn't follow the science but leads it, can I invite you to give a thunderous welcome to our keynote speaker, Professor Chris Whitty.
As I'll come on to, the thanks are all from me to you. It was a real honour to be asked to speak here. I've learnt personally a huge amount from the hospice movement and from individuals within it. But I also think that people underestimate the scale of the impact that the philosophical shift that the hospice movement has had on all of medicine, nursing and wider healthcare. And some of that I want to talk about in the second half of what I'm going to say today. But I thought it was probably sensible, following on from Toby's talk, really to talk a bit about some of the big trends that we are going to see going forward. And these are largely inevitable trends, some good, some bad, and we need to respond to them. And I think they're very relevant to the hospice care, hospice sector as they are to others, but in particular ways. And I want to start off back in 1967. This obviously is the point when St Christopher's was created, the first modern hospice was created, and you look at the population pyramid of the UK at that point, and actually the number of older people was relatively small. That's the pyramid on the left. If we look to the situation now, there's really quite a significant, larger older population, and that is going to increase steadily for the rest of our professional careers. I'm doing a report on the response of the healthcare sector to the ageing society, which is coming out this Friday. And within it, I think, those of you who read it, will see there's a lot of the philosophy which the hospice movement has brought forward, principally saying that we should be aiming for quality of life for people in older life, not just in their last few months, but actually throughout older life as our principal aim. And extending life is a side benefit of that, but is secondary to making the quality of life, the dignity of life, really central. That is what the hospice movement has taught us, and that is absolutely, in my view, fundamental throughout. Now, when we're thinking about any kind of trends, the key thing is to look both geographically and over time, because that's the way you spot big trends. Whenever you look at the healthcare sector in the next 6 to 18 months, it always looks disastrous. But actually, if you look backwards, the amount of change that we have achieved collectively and will continue to is remarkable. So just starting off with the massive changes in ill health over the last 70 years globally. And as you can see on these things, anywhere in yellow, the average life expectancy was under 50 at the point when the hospice movement in the UK really took off with Dame Cicely Saunders. And if you compare that to today, virtually every country in the world not actively at war has life expectancies now that we had in the UK at that stage or better. That's an incredible achievement. And that does mean, therefore, that globally, what people are dying of and the age at which they're dying has transformed radically over our lifetimes. Now, I'm not going to talk about the specifics of hospice care because you know far more about this than I do. But I'd like to just acknowledge several things. The first thing, straight off, is the external shock of COVID and the absolutely amazing response of hospices around the country to that, keeping their doors open in very, very difficult times, being very innovative in the way they did that, and also developing new ways of supporting people in their last months of life at a distance, for example, in COVID-secure ways that in every case would support that person to have the death they wanted, despite all the difficulties that that period put in its way. And I think the whole country owes all of you an enormous thanks for that, because it was a really extraordinary, innovative and imaginative response in difficult times. I also don't want to talk about the specifics of end-of-life care, which again is very much more your speciality than mine, but just to acknowledge that the science of hospices, and Dame Cicely was very clear that the hospice movement had to be based on improvements in science as well as on an approach to the whole patient and the spiritual and wider needs. The science of end-of-life care and of palliative care have advanced and will advance for the rest of our professional careers. Now I'm going to talk a bit about some improvements in healthcare and where I think they're going to head, and then I'm going to, in the second half, talk a bit about some of the headwinds, but we need to be aware of both of them. So this is age-standardized mortality rates in England and Wales over the last 100 years. And if you've gone back a century, infectious diseases, my own trade as it happens, was very heavily dominant, but gradually fell away. Can't come back to infections. But if we'd started the hospice movement in its modern form 100 years ago, a lot of it would have been dealing with things like people dying of TB. So those deaths have largely shifted. They're gone. There's some exceptions I'll come back to. Then at the beginning of the modern hospice movement, we were at the peak of cardiovascular disease deaths in the UK. 50% of all deaths in the UK at the point the first hospice was founded were of heart disease. Had an absolutely astonishing impact, and what we've seen over the last 50 to 70 years has been a steady improvement in cardiovascular disease. And then in cancers, they look as if they're static, but what's actually happened is some cancer deaths have gone up and some cancer deaths have gone down, largely to do with the combination of medical advances and change in age structure. So that's the long-term picture over the last 100 years. I'm now going to go into a bit more detail. Starting off with cardiovascular diseases. They have been until very recently on a steady downward slope. And that's due to a combination of factors. And the first thing I want to point out with this, and this is something I'll make a point I could make repeatedly on almost every disease, is that there's no single breakthrough. If you read newspapers, you believe that everything's bad and then suddenly everything's miraculous. Miracle cure. That isn't the reality of any form of medicine. It's small advances built on top of one another, gradually applied as the evidence accrues. And that's what you see in the cardiovascular diseases, this steady improvement over several decades, going back in this case to 1969, just around the time of the beginning of St. Christopher's. But a bit of a levelling off more recently. Now, if you break that down into the two major components, heart disease, really quite a dramatic improvement, and a narrowing of the difference between men and women, largely because of changes in smoking habits. Mainly men smoking less, sadly, slightly women smoking more, brought these two together. But an overall 75% reduction over the last few decades. A really big improvement. And what, of course, that means is that many people are going into old age in much better cardiovascular health, and you will not be seeing the rates, the prevalence of, for example, cardiac failure, age for age, that you would have done 30-odd years ago. Still a very significant problem, and one I think people underestimate the role of palliation in, actually, but nevertheless, these have shifted and in a very positive direction. The same is true, arguably even more impressively, because it's more surprising, to stroke. Stroke, when I was training as a junior doctor, there was really a pretty nihilistic view. You put someone in a bed, you say bad luck to their family, and that was kind of it. And the improvement that we've seen, both in prevention and in treatment of stroke, has been profound. But of course, that also has meant that many people are living with some degree of disability from stroke for much longer periods, and many of them will be, of course, coming to hospices in their later years, and this will be complicating some of the care that you provide. But this, again, has improved really steadily. Now, what's made up this? Well, a combination of things. Primary prevention, things the government does, things like reductions in smoking, air pollution, salt in the diet. Secondary prevention, things that the wider medical profession, more increasingly the nursing and pharmacy professions as well do, providing people who've got high risk or have got earlier disease with treatments that will delay things, and then treatment. Now, I want to concentrate just very briefly on that second of those, because a lot of what I think we can do to mean that people enter their last years in the best health and therefore have the best quality of life is around prevention of disease by pushing it off to the right. You can't stop someone getting a heart attack. You can delay it till after they're dead. You can push it off to the right. And therefore, what you can do is actually minimize the number of diseases that people have as they go into that last period, and that will, of course, improve their quality of life significantly. So now moving on to cancer, again, several improvements in cancer prevention. I'll come on to one specifically in a second, but also very profound improvements in cancer survival from many cancers, but unfortunately not all. And therefore, you will very seldom now see, relative to where it would have been 20 or 30 years ago, and these data are not published, they're Cancer Research UK data, they're improving them, so please don't publish them on their behalf, but they gave me permission to show this. What you can see is that several cancers which previously would have caused really significant issues and many people going into hospices have really now become largely survivable chronic diseases, or ones indeed which are entirely cured. So, for example, testicular cancer, near 100% survival for most people. But at the bottom of this, unfortunately, and these are ones which, of course, all of you will see all the time, diseases including ovarian cancer, myeloma, brain cancer, stomach cancer, esophageal cancer, and above all, lung cancer, where the improvements have been less obvious. So as we get better treatments for cancers, the balance of which cancers are seen in the hospice movement is going to shift, because some of these are going to be entirely survivable, meaning 10 years on you still have a good quality of life, but some, sadly, are not. And just as with cardiovascular disease, this is incremental. You can put a ruler against these and guess where we're going to be in 10 or 15 years' time. These are incremental improvements based on small additional improvements over time. But they are not ones where you see sudden dramatic changes. Very occasionally you do, but relatively rarely. It is usually small incremental improvements. Sadly, that is also true where we are not seeing improvements. So here is lung cancer over the last 10 years, and the depressing thing about lung cancer is that we have seen improvements in 1-year survival, but much more modest at 5-year, and at 10-year, virtually not at all. It's a tragic situation. Many of you will see many patients with lung cancer, and the double tragedy of this is a disease largely caused for profit. I am so relieved that the Prime Minister, with all party support, is bringing forward the idea that we will stop all smoking from the age of those aged 14 or below. For future generations, this will be transformational, but for now, the diseases of smoking, lung cancer and chronic obstructive airways disease in particular, both of which come to hospices in large numbers, unfortunately will be with us for a long period of time. Moving on to infectious diseases, our ability to combat infections is one of the areas where we have repeatedly shown we do have the ability to actually stop disease before it actually gets to severe issues, at least in younger patients. And I'm just illustrating this with 2 diseases. Cervical cancer, where the probability that someone with cervical cancer will be coming into a hospice will be steadily decreasing for the next 30 to 40 years, largely due to vaccination of children young girls and then subsequently boys being vaccinated is going to lead to this being almost eliminated as a disease. It'll never go away absolutely completely. And as an interim measure, screening. But we still sadly do see women dying of cervical cancer. But HIV on the right, a disease which was actually my first direct experience of palliation. Working in southern Africa at a period when 30% of pregnant women, which was a proxy for people who were young adults, had HIV and there was no treatment. Very large numbers of people dying a very unpleasant death. And seeing the Lighthouse Hospice in Malawi being built and then producing its results, I think demonstrated the transformative effect of the care provided by hospices, including in infectious diseases. Really remarkable changes to the way people thought about disease and indeed started to change stigmas for dealing with things like using things like morphine, something which Dame Cicely would certainly have approved of. But infections will always, of course, be with us, and they will always complicate the management of particularly older adults who are living with frailty or multimorbidity, and they will certainly continue to complicate the efforts of all of you as you deal with people in later life. Some diseases have greater impacts on people's quality of life than others, but all of them will reduce the quality and lead to intercurrently to people becoming very unwell, often at periods when they had not really, this had not been planned for in any way. So those are diseases which are going to changing the face of mortality. There are also quite a large number of very profound changes in morbidity, and those I'm going to highlight the diseases of inflammation. So, for example, rheumatoid arthritis, which used to cause very significant problems, still does, but people with very severe rheumatoid arthritis, people with very severe inflammatory bowel disease, which will cause problems for the rest of their life subsequently, are many fewer than they were because of significant improvements in treatment. So here's an area of medicine where actually people are going to enter older age and enter their period of the last years of their life, usually in much better health than they would have done prior to improvements in medical science. But there are many areas where that has not been the case, and I'm going to highlight in particular mental health. There have been improvements in treatment, prevention, treatment, and diagnosis of mental health, but they've been nowhere near as profound as the kind of ones I've showed for cardiovascular disease, cancers, and some of the inflammatory diseases. And therefore, the issues of management of mental health, which all of you have as central to hospice care in all its forms, I think are less well advanced now from the 1960s than many of the areas of physical care which we've looked at elsewhere. And I think this is something which we as a profession as a whole, and I'm not talking specifically about the hospice movement, really need to take very seriously. But overall, I've given a pretty optimistic picture of things we've done to improve the disease states of people as they enter older age. And this has been across the whole country, although there has been variation. I'm now going to turn to the and but bits of this. Life expectancy at birth, which is a proxy for health overall. So I'm not using this just as mortality, has taken has flatlined largely across much of Europe over the last 10 years, and of course has taken a significant downward step during COVID, as Toby showed in his initial presentations. So many of the improvements that we've seen, which were, it looked as if you'd taken it up to about 27 or 28 for the sake of argument, almost inexorable since the 1860s, have now really flattened off. And that isn't because medical science has slowed down. We also have a number of rising challenges, of which the biggest one, which is going to complicate the efforts of everybody in medicine and nursing, and particularly actually in hospice care, is rising obesity. People who have multiple problems as a result of something which is only now going to start to really be seen. So the rise in people living with obesity, which is a worldwide phenomenon, this is not a specifically UK phenomenon, is meaning that that this big rise is only starting to get to the age when people are affected in their later life. And we'll be seeing both diseases of people living with obesity, cardiovascular diseases, some cancers, for example, mechanical issues, difficulties of steadiness, for example, will be exacerbated. All of these are going to play through over the next several decades. We also have a significant remaining issue, a persistent issue, of areas of deprivation in the UK. And if you look at the map of under 75 mortality on the left and relative deprivation on the right, they are virtually the same map. And again, under the mortality, you've got a huge iceberg of poor health and people biologically aging very rapidly and having multiple diseases well before their time. And this, again, will play through to what is seen in hospice care. Even more depressingly, some areas of that map, if you do a map of child deaths in the 1860s, the map looks remarkably similar. So this is very, very enduring deprivation and poverty, which we must societally address. But the other big driver, along with deprivation, of course, is age. And here I wanted to make a really quite practical point. The population is aging, we know that, but what I think lots of people have not really appreciated fully is that it is not aging in any sense evenly across the country. The general tendency in the UK is to go into a city at 18 for study or work and to leave after your second child or shortly afterwards. That's the standard approach. Other countries do it differently, but that's the British approach to this. The result of that is that the cities remain forever young. And the rest of the country has to actually balance the equation. Now, that has got a lot of very important practical implications for us. So if you look, for example, at Wandsworth on the left, Wandsworth will look very similar in terms of its demographics in 30 years to what it does now, young. If you look, on the other hand, at Chichester, what you see is two things, both an aging population, but also a lack of younger people. And that is relative to the older population. And given that one of the major issues, Toby and I were discussing this morning, which the hospice movement faces, is staff to staff hospices, if we end up with a situation where the age support ratios are getting steadily worse in some parts of the country, that is going to be a significant issue that we need to think through, I think, collectively quite seriously. And this also means that the burden of care, and I'm using coronary heart disease only as a proxy, is becoming more peripheral because it tends to be where you get the combination of older age and deprivation. And the more peripheral you get, meaning coastal areas, rural areas, the more that's true. And these are areas it's harder to provide care, it's harder to provide distance care because actually the physical distances are longer. If you're in Lincolnshire, you realise this, or North Yorkshire or Devon. And it is harder to find the numbers of staff needed to provide things. So this issue about a mismatch between where the ageing population is and where the population as a whole is going to be quite, I think, quite a serious one for us all. And of course, for the age of people using hospices have historically been younger than the average age of people dying for a variety of reasons you all know. These are Hospice UK data. But I think this is likely to shift as we see significant demographic shifts in the population. And I'll show why in just a second. And I think this, again, will require some rethinking for all of us. The reason I think that is that the mortality change that we're seeing has actually remained fairly impressive in people in their 70s or below. So mortality is continuing to drop in that age group, and in my view, will continue to drop, and the same is to a large degree true for people in their early 80s. Whereas people in their late 80s and 90s, there has been virtually no improvement in mortality over really quite a long period of time now. And my view is that is going, in fact, to persist. What that means is that mortality is becoming increasingly concentrated in quite a narrow age range in the UK, and I see this trend actually continuing to occur. There seems to be an upper age. It's really quite rare now for people who are not living with very significant disability from younger life or in very significant deprivation to die before their mid-70s. Most it'll be towards the end of their 70s, and it's still pretty rare for people to die after their mid-90s. And that concentration of age of death is becoming more profound everywhere in the world, but particularly, actually, taken specifically in the UK. So that is going to be something which I think we need to think through, and I think if you look back to that previous slide I was showing in terms of age at which hospice services tend to be most heavily used, I think we need to take that into account. We also, as Toby talked about earlier on, are going into a period where there are many diseases of old age for which we do not have good treatment, and I'm going to use the dementias, Alzheimer's dementia, vascular dementia, Lewy dementia, as a proxy for that. But there are others, and this obviously also goes into frailty. This provides challenges for some elements of conventional hospice care, where it's very difficult to communicate with people in their later life. And this is something which, again, we collectively have to think through. And finally, in terms of data, before I bring some themes together, we have individual chronic conditions accumulating with age, multimorbidity. This is something which all of you see, but as the age at which people die goes up, at this point in time, and unless we do something differently, and I think we should, which is the reason I'm writing my annual report, but unless we do something differently, we're going to have a situation where at the point people die, they will have more diseases over time than they had in the past. So it would be fairly normal for people historically to die with one or two diseases in their late 60s or early 70s. By the time people get to their mid-80s, very large numbers of people have multiple diseases, apparently unrelated to one another, although they may have a single cause, diabetes or obesity or smoking, for example. But the result is we're going to have multiple diseases to deal with symptomatically for a much higher proportion of people as they reach their final period than we would have done historically. And again, I think that's something we need to think through. Multimorbidity is increasing and will continue to increase. It occurs at an earlier age in people living in deprivation, but it occurs across the whole social spectrum. So, what are the implications of this? This is my final kind of bringing this together. The ability of medical science to move the age of end-stage single diseases to the right, get people to live for longer, is going to continue. And particularly for people in their late 60s through to late 70s, I think we will continue to see quite significant improvements. Several of the diseases which kill people in young or middle age will cease to do so. I've highlighted two, HIV in high-income settings and cervical cancer, but I could have highlighted quite a large number of others. However, the aging population is going to grow, and it's going to grow almost exclusively in the periphery, where it is more difficult to provide services, and indeed, from an economic point of view, where support from the voluntary sector may be more tricky for a variety of reasons. And I think how the hospice movement thinks about that and responds to it, I think is going to be quite a significant challenge. Multimorbidity is already an issue for most people who are in their last months of life, but will become more so, and for a longer period of time. And that is, again, something we need collectively to respond to. But my final point is a plea, really, to people in this audience to help the rest of us in the medical, nursing, and other professions with the fact that the generalist skills of the medical profession, to a lesser extent the nursing profession, have become eroded over the last 30 years. We have had a situation where greater specialization has become the norm, with a less patient-centered care, in my view, because people are getting better at more and more specific things. And for people living with multimorbidity and for people living with multiple conditions, medical, physical and mental, this is quite problematic. And I think as a medical profession, and as I say to some extent in nursing, I think we need to relearn how to maintain generalist skills, including the kind of approach to the whole patient which comes from this movement, in addition to the specialist skills. Those two are not, in my view, in conflict. And I would like to see the kind of thinking that has come from the hospice movement extend much further away from the point of death, down the age range, into the period of older age, so we really are concentrating collectively on quality of life and the whole person, rather than specifically individual diseases, important though those are. So I think this is something which it doesn't just stand in hospices, I think can extend more further out. But I'd really sort of finish where I began. I have huge admiration for what all of you do, as I think the entire country does. I've got enormous thanks for what you did specifically in COVID. I've learned a lot from the hospice movement and individual people within it, but I think there's a lot more we could do to embed some of those philosophical positions and some of the skills about management of symptoms and quality of life in the wider medical and nursing professions, and I would encourage you to help us do that. Thank you very much.
So, I'm not entirely convinced that Slido is working. Has anybody sent a question? Slido may be working. No one's sent a question. So, while you wind up your fingers and start sending me some questions, Chris, I was really interested in what you had to say about adding quality to life as well as adding length to life. Do you think there's more to be done around helping clinical professionals to have that difficult conversation about, do you really want to carry on with this treatment? Do you really want a longer life? Or
yeah, so all of you will have experiences of this, but there has been observably a shift in this during my clinical lifetime, actually. And I would say general practice is still good at having that conversation. They know patients, they know families, they can have the conversation early. But I think the medical profession has probably found it harder. Certainly it has not got better, and arguably it's got less good over the last 30 years in having that conversation that is not actually about, as you would have it, actually you're coming to the end of your life, but rather actually you've got quite a lot of life left. You can choose to some degree. There are things that we can do which will help your quantity of life but will possibly reduce its remaining quality. Or we can go the other way. Which one would you like to have? And I think it's very patchy, and I think this should be universal, because actually, we are all going to die. You above all know that that is the central thing, that we are all going to die. What people want is to have the kind of dignified life with their family, with their friends, with the ability to do things. And we can do three things on this, I think. We can reduce the disability by shifting disease off to the right in time. We can alter the environment so that people with the same amount of disability can have a good quality of life. Really quite small things can often be useful on that. But the third of which is to have that conversation that says, actually, where are your priorities? Ultimately, it has to be for the person themselves to have that conversation. And the further away they are from a point of clearly seeing death as a relatively short-term outcome, the more balanced those decisions may be. But nevertheless, I think the conversation should be had and had repeatedly with people in an open way, and people should get used to it and feel comfortable with it. And that, I think, would allow a lot of people to live probably as long, but in much better quality over time. And I think that's something which this movement, above all, can exemplify.
It's great, thank you. So a question that follows on from that, which is, I think, fits really well. What can be done to create a policy shift towards a mandatory training in palliative end-of-life care for the generalist health and social care workforce?
Well, I think that any sensible, certainly physician, probably craft specialties as well, who doesn't want to have better training in palliative care hasn't really understood what they don't know. And I think the level of lack of knowledge of some of the key technical skills, in addition to the philosophical point I was making previously, I think a lot of people, I see a lot of people still on wards who have more pain than they need, who have more nausea than they need, who have more discomfort or other symptoms that are really eroding their quality of life, and of course therefore increasing their sense of pain and depression and many other things than it should be the case. And we cannot, we're never going to be able to have enough palliative care specialists to look after all of them, at least not for the foreseeable future, but we can train doctors and nurses working in those environments to have a much better understanding, and the expertise is with you, and then with people in the wider palliative care movement who obviously extend a bit further back in time. But I think mandatory training on this, in my view, is an extremely good idea, and it's one which, I think if if you were feeling you wish to offer it, I would be very happy to talk to the Royal Colleges and suggest it to them. I'd be very surprised if they didn't seize it with both hands, because it is something which I think all of us realise is a gap in provision.
Thank you. Change the theme a bit. The slides show projections around inequality. There was quite a lot in there about age. What about ethnicity inequality?
Well, ethnicity, obviously, well, first thing to say is that the first generation migration has really passed, and people are moving into their older age. So we have a much more diverse older population than we did 30 or 40 years ago. That's a good thing, but it's a thing. It has a number of features. I mean, you are, in a sense, the implication of the question is right, that ethnicity and deprivation has tended to coincide, not across the board. It's much more complicated than just saying if you're an ethnic minority there will be more deprivation, or vice versa. It is more complicated than that. Nevertheless, there are certain ethnic minority groups, for example, people of Bangladeshi and Pakistani heritage in parts of the Midlands, where there is a heavy concentration of deprivation. And this was really clearly, in a sense, signalled during COVID. You could see on the maps where these heavy pockets of deprivation were, and then that fed through, sadly, into mortality and morbidity. But it's the same is true in many other areas. So I think we are absolutely right that we need to think about ethnic minority groups. We also need to think about them in terms of cultural norms and expectations, so that we meet those expectations where they are in any sense different from, in a sense, conventional white British middle class assumptions. It's really important we recognise them, we respect them, and we respond to them. They can be exaggerated, but they will still exist, and I think it's important to think that through.
Thank you. Questions are now flooding in. I promise I'll try and get back to ones that are slightly earlier up the stream, but it's quite difficult to catch it when it's coming in a torrent. Going back to the workforce issue for a minute, I thought that map you showed of older age being on the fringe of the nations was really interesting. So in my home city of Birmingham, around 44%, I think it is, of the population are age 30 or under. How are we going to encourage them to go to Chichester to look after the
Well, I mean, obviously it helps.
Houses they can't afford to buy.
Yeah, it helps if they've got money and like sailing. I think that the easiest thing we can do, it's a long-term answer, but it is an important one, is to make sure a lot more of the training is done in the periphery. And I've made a strong case to the NHS that I think all the expansion in training, I'm not saying contraction elsewhere, but the expansion of training should occur in peripheral areas, because there's a lot of evidence, for wholly unsurprising reasons, that people tend to work where they train. They tend to have partners where they train, they tend to have social networks where they train, and therefore if you train people in London and Birmingham, don't then expect them to go to Chichester, but if you train them much closer, there's a much greater thing, and the same would be true in other areas. So I think that's the first one. I think that there are some mechanistic issues that we need to deal with on this, and I think my view is we need to be looking at things like pay and conditions and all the other barriers that people have. But some of the barriers to people doing it, I have to say, are ones which are quite difficult for the health service to sort out. For example, people need to have access to good schooling. They need to have access to a whole variety of other things. They need to be close enough to their families that if their elderly relatives need help, etc. There's a large number of factors like this which are out with our control. And I think what we should do is control the things we can control as best we can, of which training is the most important, but accept there will always be some difficulties here, and we have to be imaginative about it.
Yeah, I was going to ask you about that, because I mean, excuse me if I'm sort of making it a bit hackneyed, but in many ways, health and social care deal with the consequences, don't they, of policy, and accept what you say about there not being golden bullets. But if you look at some issues, like, for instance, I mean, perinatal mortality, sorry again to go close to home, but perinatal mortality in Birmingham, frankly, hasn't really shifted in the last decades. How do we, from a health perspective, influence the broader, whatever it is, policy sphere to try and make some of that fundamental shift? Is that at all possible, or is it just
I think it's possible. I think we should differentiate in this, between, in that perinatal mortality, take that as an example, what are the deaths which absolutely cannot be avoided and where a good quality of death actually is still important among children. Toby, for you, for example, ran a children's hospice. This is a really fundamental and really difficult part of hospice care in many ways, but also which are the ones which we could have prevented. And this heavy concentration in particular areas, particular ethnicities, are largely preventable. And the most important thing to start the conversation is to have really clear data. The more granular the data is, the more it really stands out. Once you've demonstrated a problem, you then have to be able to say, here are some solutions to that problem. But in the case of perinatal mortality, we know how to do this. There is a set of things we know will reduce that, not to zero, it'll never reduce it to zero, but significantly down from where it is in the worst affected groups. And I think we should not have any hesitation about making really clear this is an avoidable tragedy.
Yeah, thank you. Lots of questions about money, you won't be surprised to hear. How do you foresee the future of hospice charitable care in the current fundraising crisis? If the government gave more funding via NHS, would we hospices be bound by NHS standards? That's a very formal question. Look, so I'm an NHS person through and through. However, I would not want hospices to be run like the NHS because I think we actually provide a better quality of service. You know, we have higher levels of workforce and so on. How do we have that conversation sensibly with government, the NHS funders, and at the same time, of course, dealing with the issue of the fact that we have, because we're charities, we have to have reserves to stay alive, and they go, well, you don't need any more money, you've got £8 million in the bank, what are you on about? How do we get into that, do you think?
Well, I'm going to, at one level, weasel out of that, because I've always taken the view that for government money, that's not my area. That's what politicians are for. I mean, I don't, you know, I'm there to do medicine, science, and so on, and I need to be a bit careful. I don't stray into territory that isn't mine. But of course, like many people, I'm a trustee of charities. I understand the difficulties of this, including the point about reserves. I actually think, Toby, you're in a better position to give a proper answer to that. And I'm going to demonstrate delegation. Yes.
That was... Yeah. Thank you for the hospital pass system.
Well, it's complicated. Yeah.
Is that it? Is that your answer?
Yeah. I think we need a new deal. We need to approach this in a different way. We need very strong data in order to illustrate the impact of difficult financial times on services rather than on percentages of funding and reserve levels and everything else. But I think certainly the thing that I have appreciated most in my year with Hospice UK is the extent to which if you rely too much on charitable funding, the relationship between hospices working in more deprived areas will be the ones that will find it hardest to maintain services. And if you then layer that across the deprivation and morbidity data that you showed us, that is a very uncomfortable aggregate picture, because it will mean the services are being taken away from the communities that arguably most need them.
Yeah, I agree.
And I'm glad someone agreed.
Yeah, I also agree with that. Yeah.
May I ask one question, just about, because he'll never allow me. I can't put in a slider.
You've got to do a slider.
It was like we talked about earlier. I know that you'll be giving evidence soon to the COVID inquiry. But if you're able to, one of the things that was obviously very dear to us as the hospice sector was how people die. And in hindsight, you know, what do you think we learned about end of life during the COVID pandemic? Many hospices here, if you like, made huge efforts to maintain access, family access. What is there anything that you yourself learned and on this topic during the pandemic?
Yeah, well, I mean, with the slight caveat, I have to be slightly careful because until I've given evidence to the inquiry. But firstly, as I said earlier on, I think the hospices were incredible in the way that they actually flexed their services to provide a good quality of death for people under extraordinarily difficult circumstances. obviously nowhere near where people would have liked to have been, but the ability to respond to that I thought was remarkable. I think if we were to rerun things again, end of life is one of the areas I think we should have looked at really seriously and asked the question, have we got the balance right? I think the other one, of course, is care homes, access for families in care homes. But that's a more difficult balance, in my view, because there was the difficulty that the risk to other residents, where the expectation was that people might have several more years to live, potentially, was a real worry. And what happened in the first wave, I think, led to a very considerable political and social concern about mortality in care homes. In hospices, that isn't a concern, because by definition, people have reached a stage where they are on a final pathway. An infection may speed that pathway up, but nevertheless, the path is reasonably clearly laid out. And the ability to say goodbye to people properly is, as all of you know, very profound. Different cultural groups have slightly different ways of doing it, but it is absolutely central to every culture, every religion, every part of society, that you have some way of actually, in both directions, having that link. And I think, did we manage that right? Personally, my view is I would like to revisit that pretty heavily. I'm not convinced a public inquiry is necessarily the right way to do that. I think we need to do it, in a sense, collectively. And I think having the hospice movement leading that discussion in a kind of no-blame, what would we do if we were doing this again way, I think would be very helpful, because we won't face the same pandemic again, almost certainly, but we will face major threats again, where infection control versus access to people who are dying will be in tension. And I think we need to work out what went well and what went badly among ourselves in a way. Don't expect others to do it for us. I think we should own that, and I think particularly the hospice movement should own that.
Thank you. Can we build on that with a question quite a lot of people have supported, which relates to the well-being of the workforce? We obviously work quite hard in the hospice sector to try and maintain the well-being of our workforce, but it can be quite a tough world to work in. What lessons do you think we learned in COVID about how we can support each other better, or maintain our well-being?
Well, I think that the two things that were really clear was that team becomes even more important in a crisis. If you've got a good team around you, the ability to get through what appear insuperable things is massively greater than if you're trying to do it on your own. It's an obvious point, but it was really heavily demonstrated. And therefore, the ability to create and maintain teams is really central. And the second is purpose. If people think what they're doing is important, because it is, that does make it easier to get through, again, more difficult things. And if essentially people's view is not that. Now, on the second of those, the hospices and palliative care more widely, the sense of purpose, I think, is really clear. Very few people go into hospices unless they think it really matters, and most of society would agree it matters. It isn't this is a kind of widespread societal view. This is a really important thing that all of you are doing. On the teams will be more variable, and they do depend on team structures, they depend on leadership, they depend on external structures, they depend on having a reasonably stable core team. If you are reliant entirely on people who are coming in and out, however good, that doesn't allow for the creation of teams in the same way. So I think there are a variety of things and I think thinking through how you maintain a team, I think is really important. And I think most hospices do that very well. They do feel a community, but you can go in occasionally to hospices and feel that the team is not quite at the point it has been previously. And that's always, I think, a warning sign, because it is difficult what all of you do. It's emotionally draining. It's challenging in many different directions. And having a team around you, I think, does make that a lot easier.
Thank you. I'm going to skip the questions I've got about money, because we've dealt with those as best as we can.
Yeah, get Toby to answer them in the break.
Yeah, well,
yes.
You just keep repeating what you said already,
yes.
So we'll take that as read.
Yeah.
I've got several people asking about the potential for assisted dying or suicide becoming part of the options of dealing with the burden of approaching the end of life and the burden of morbidity. Do you think is that coming, do you think?
Well, I think, so the first thing is that I think that it should never be seen as anything that's even considered as a response to a burden. That's an absolute no. I think that there is a societal shift on this issue, but where it has got to, I don't know. I've always taken the view that this is a societal decision. The hospice movement is slightly different, but as a chief medical officer, my view is if society, as demonstrated through Parliament, goes in one direction, then that is a societal choice. If it goes in another direction, that's a societal choice. Fundamentally, the question will never be, should there be every effort to make all deaths a good death? The question really hinges on should people be allowed a choice about when they choose to die. And I'm not expressing a view on that. I'm just saying that I think society, from time to time, has to come to a decision on this, because it's quite a profound question. We have a current settled position in the UK. It's different to some other countries, demonstrating it is possible to have other positions. And I think the debate will, from time to time, happen. My kind of view is we should have it, it should be open and honest, and then it should stop, and we should then wait for a bit and see if society changes. But as a medical person, I think it's wrong for me, personally, in my role, doesn't mean you have to feel this, to actually say, I think it should go one way or I think it should go the other. I do think this is a societal choice.
Yeah, I think, for people who work in hospices, what I hear is that the issue is one that's often, well, not often, but is sometimes raised by relatives. Then it becomes a much more personal business, and we're I think, hopefully trying to develop some resources to assist people in having those conversations without, like you, we don't have a position on it. We just say that we're not having a position on it, but we have to be part of those conversations in the clinical real world where people are working and talking every day.
And lots of people in this audience will have a strong position on it, and that's entirely legitimate as citizens.
How do we, shifting the ground a bit, how do we encourage that broader conversation with wider teams, given the shift towards different kinds of end of life, particularly, I suppose, that frailty and dementia that you were talking about? How do we make that happen, do you think, Chris?
Well, I think that what we, and this in this answer, I'm going to extend a bit further out to wider palliative care than just hospices, but I think in a sense it's a continuum rather than just a binary divide. I think that we should kind of say, well, what are the things which really should be managed by a specialist, all of you? What are the, what are the things that should be managed by other groups, probably generalists, but with some input from you and colleagues like yours who can provide some additional information? And what should we be doing by actually improving the general level of quality of palliative end-of-life and indeed quality of life care across the whole of the health service? My view is that you're the people who are best to judge that, but I would really encourage you to see that the third of those is something which we're not doing enough of. And that actually raising the whole quality of provision in the medical and nursing and other allied health professions of how we think about quality of life in the last many years, not just the last many months, is something which I think we should do a lot better. And the skills are in all of you very often rather than in many other areas. As I say, I think general practice is better, but certainly I think with general practice, I think there's really quite a gap, frankly, in many of these areas.
Do you think we'll get to a point where we spend less on medical technology to fund more basic health and social care?
I think we'll always do both. I think where the trade-off is should be made much more explicit. So you tend to get high expense, high excitement technologies will dominate newspapers. There'll be a front page news thing, they'll be in the Today programme and so on, in a way that the provision of, the fact that 1,000 people have had really excellent incontinence care does not. And I think we need to be very careful of that, because many of the things that are coming through are extremely exciting, and understandably, the parents of the child or the daughter of the parent who would benefit from this extremely exciting, very expensive medicine is going to advocate for it, and perfectly rightly. But actually, societally, we are going to have to make some difficult choices, and I think we should expose them. not just do everything on basic care and stop all the most high-end things, but nor should we be sucking almost all the basic care towards the exciting and the novel. I think it's getting that balance right. And I think in some areas I think it is right, and in some areas, in my view, it is not. And I think it's usually where the trade-offs are not properly laid out.
Yeah. Do you think we're good at explaining what's going on to the public? So, for instance, everybody knows that GPs are all idle and doing nothing. But the truth is actually they're doing 20% more contacts than they were doing before COVID. But the public myth now, the accepted myth, is that they're all useless and they never do any work. How do we get a better communication and dialogue and debate going about what's really happening, do you think?
Yeah, I think that I've been very saddened by some of the commentary on general practice that has been in the newspapers over the last years, and I was even more than saddened when some political commentators chose to give credence to it, which I thought was poor, frankly. The reality is that general practice has got three separate sets of problems, the first of which is their numbers have not gone up, but the amount of work that they're expected to do has gone up. The maths doesn't add up, basically. They've also got a very significant rain shadow of work that's still coming back over COVID. And then thirdly, they have a lot of the problems of getting staff in the most deprived areas, the most peripheral areas that all of you have in spades, actually. If you try and, if you talk to colleagues around the periphery, for example, real difficulty in getting both doctors, nurses, and other people. So I think we should be a lot more upfront about this. We should not expect a fair debate, because debates in the public domain are not always fair. But we should at least expect one where we actually stand up and say, as professions, actually defend one another on this, and when it's reasonable to do so. And I think it is important that, and I will say very clearly, I think general practitioners do an amazing job under very difficult circumstances, by and large. We just need to think of a new way of dealing with the fact that the ratio of demand to supply has got significantly out of kilter compared to where it was 10, 15, 20 years ago. And what are we going to do about that? And a lot of that is about training doctors and primary care nurses and so on for a medium to long term. There's clearly going to be some of that's about changing different specialties and how they work together. Where is the risk held between medicine and nursing has shifted over my professional lifetime. That's a good thing. But we need to formalise that, I think, more thoroughly. But I think we also need to be honest about the problems and not try and hide them. But that is, unfortunately, a counsel of perfection. It's not how it's playing out at the moment.
Okay, thank you. So,
my main advice to my GP colleagues is never worry about criticism from people you wouldn't take advice from.
So I'm afraid I'm going to have to wind things up with one last question. Having said there are no silver bullets, I've got a question that's asking for a silver bullet. What's the one thing that the hospice movement can do to better place end-of-life care as a priority for the NHS, Chris?
I'm afraid that the dull answer is continue to advocate for it as a central part of the whole system, of which you are, in a sense, the apex, rather than as something that's off to one side, where at a certain point you kind of stop medicine and start hospice care. Those two seem much more as integrated. I don't mean integrated in a kind of mechanistic payment sense, the point that Toby was making and you were making about how we do that. I think that's a separate discussion. But actually in the whole philosophy of how it's managed, and I would go further and say stretch it further back in life so that it's seen as a much more gradual movement towards the point where actually end of life, you're 100% on quality. But actually starting to think about that much further down the line, I think avoids abrupt transitions, which I think are tricky and, in my view, not realistically where most patients, most members of the public, most families are.
Thank you. Thanks very much. We're going to move on to the awards now, but I think Toby just wanted to say a few words first.
I just wanted to thank you for being here today. We're immensely honoured and happy to have you with us. It's been a great talk, and I think everybody also would want me to say thank you to you for how you helped pull us all through the pandemic. And I think this is an audience that can recognise a public servant of immense goodness and integrity and a great communicator. And we'd all like to thank you very much.